why is it that as a society we now feel it's that important? You know, these medications were developed with people with life-restricting obesity.
Yeah.
They weren't really developed for people like Robbie Williams.
Welcome to the Silent Epidemic by Omniotherapy. I'm your host, Hatice Mehmet-Quirk. Today I'm joined by Dr. Bryony Bamford, founder and director of the London Centre for Eating Disorders and Body Image, a specialist clinic dedicated to evidence-based treatment for eating disorders and related body image challenges. A highly respected clinical psychologist, Dr. Bamford has devoted her career to understanding the psychological, emotional and social factors underpinning eating disorders and to develop compassionate, effective pathways to recovery. Her work blends clinical expertise, research and deep commitment to providing personalised treatment for individuals and families. Dr. Bamford, welcome to the show. To begin with, what inspired you to create the London Centre for Eating Disorders and Body Image?
Well, thank you for the lovely welcome.
Thank you for joining us as well and taking the time. I really appreciate it.
No problem. So the London Centre now, incredibly, is almost 15 years old, almost. So thinking back to when we started, my hope at that point was really to create something that was quite unique at the time in the field of eating disorders. My history had very much been within NHS services and within research services, and I really wanted to take what I saw as the best bits of the NHS. Because the NHS, if we're honest, you know, if it were resourced well, would be the most incredible service in the world. And there are some incredible clinicians doing wonderful things. But there's also real frustrations, right? Resource frustrations. There's long waiting lists. There's a limit to how long you can see somebody for. There's all sorts of sort of difficulties, I guess, when you bring resources into play. So I really wanted to bring something that combined the best bits of the NHS, the evidence-based treatment, evidence-based informed treatment, with an ability to really think individually, really think compassionately, really think collaboratively, and make treatment more accessible to people in need. So we very much see ourselves as an expert clinic, but without limitations on who we will see. So we don't shut the door to anybody. If people want to come and work with us, and then that's appropriate, we'll very much offer what we think they need. Yeah.
So it sounds like and again, as you've quite rightly mentioned, the NHS, if it wasn't so overrun, would work exceptionally well. But, you know, funding and number of people using the service, etc., etc. But the processes, the clinicians they have, the evidence-based works, but they're unable to doctor that approach to meet the individual where they need to be met, because it's almost like they have to follow a tick box structure and routine.
Potentially.
And you try to adapt that so that you can make it unique and bespoke to meet that person when they need to be met.
Well, I think what can be difficult as an example is sometimes, you know, there's very long waiting lists in the NHS. So sometimes people will present to treatment for an assessment at a point that they're ready to make change. And often it's taken them years to get to that point where they're ready to make change. In eating disorders, often people have difficulties, have real struggles for 7+ years before they even present to treatment for the first time. So they're coming ready to make changes, but then they're sitting on a waiting list. And what happens then, of course, is they lose hope, or they lose that motivation, or things get worse, and it's then much tougher to effectively treat. So we try to offer a service that is there for people when they're ready to make those changes. Equally, you know, of course, rightly so, the NHS will follow NICE guidelines. So you'll get 20 sessions, maybe 40 sessions. And that is enough for some people. Absolutely, that is enough from some people. That number isn't sort of plucked out of nowhere. But it is informed by what amount of research funding was there to trial these therapies. So there are a lot of people that just need more, right? That within 20 sessions, they can do a meaningful piece of work and they can really look at the symptoms. But the symptoms is just the surface layer, right? What they don't often or always have time for in those 20 sessions is to really do that deep level emotional change work. And I think that that's one thing I wanted to change, was to be able to have the opportunity, not just to work at the symptom level, surface level change, but to be able to work with someone for as long as they felt they had work to do and they had change to make. And that's what's so wonderful about working privately, is that you can integrate, you know, your CBT, which we know works, with lots of other models in order to create a treatment model that targets what we really need to be targeting to work for that person.
Nice. Just a quick break from today's episode. If you've ever tried to get therapy, you know how frustrating it can be. You're finally ready to talk to someone, but you've been stuck on a waiting list for months. That's not how mental health support should work. Omnia Therapy makes getting help simple. You can book a session with a fully qualified professional in just 24 hours. No waiting, no contracts, just real support when you need it. And at £40 per session is actually affordable. If you're struggling, don't wait. Tap the link in the show notes or head to omniahealthgroup.com to book your session today. When you look at the treatment landscape at the time, what needs did you feel weren't being fully met?
I guess it's similar, right? It's the waiting lists. It's the models that work for the people that don't fit into the standard evidence-based models that we've got. So we know CBT, as an example, can be really effective, but no one model is going to be effective for everybody. And I think what can be really problematic is that there can be the sense that if this isn't working for you, there's something wrong with you. Not there's something wrong with the model, or we need to try a different model, or let's look at let's look at a different approach, or let's look at what you need. Often I think you can get this message that, well, there's nothing else, so therefore there's no hope.
We hear it all the time. Oh, I'm beyond help. There's no help in me.
This didn't work and therefore there's nothing else and nothing's going to help me. And I find that really frustrating because I do genuinely believe that everyone can recover. Doesn't mean everyone will recover, but that everyone can recover if you combine the right time, the right approach, and take the pressure off needing to recover within a certain time frame. I think that's really important.
Oh, absolutely. That time pressure can
be really unhelpful. It can be really unhelpful to have, if you're not better within
these sessions,
6 sessions, 8 sessions, 12 sessions, then you're not going to get better. I do believe in time-limited care, and I think that accountability and a sense of this is our opportunity, let's do it now. I do think that can be helpful, but I think that's got to be balanced with going at the right pace and meeting a client where they're at.
Because sometimes, as you said, it could take 20 sessions for someone to even come to terms with what's going on the surface level. Talk less of get any deeper than that.
Well, you might have someone who, it takes a while to even be able to sit in a room with you, or it takes a long time to even accept that diagnosis, if you've given them a diagnosis, applies to them, that it takes ages to actually be able to open up to themselves as well as to you. And of course, when you apply a 20-session model to those people, then the amount of time that you've got by the time they've opened up to you and they've been able to do that initial exploratory work and they've got a formulation that they can work with, well, then you're running out of time. So absolutely, I think 20 sessions, you can do it in 20 sessions. I'm not saying you can't, but I think the luxury to be able to use longer and adapt and be flexible and meet a client where they're at is really key. And that's something that I wanted to try and achieve.
Why was it important for you to build the centre around proven, research-backed approaches?
I guess at the time, I felt as though, evidence-based care is really central to I'm a clinical psychologist, and so it's really central to your training as a clinical psychology to be a sort of a scientist practitioner, a reflective scientist practitioner. You know, that's a core part of your training. But I also think it's really important that we aren't just left doing kind of anything, you know, that we think. I think it's really important to be looking at the research and listening to clients and actually thinking about what do we know works. I think it's really helpful as a clinician to have a model that you are being informed by. I think it's really helpful to be able to describe different models to clients and say, look, these are the different possibilities that we have. These are the different areas that we can work within. I think it's so key to be able to draw on what does the research tell us is effective for different people. So at the time of starting up the clinic, I think you had NHS services doing that really well, looking at evidence-based, and then you had perhaps independent clinicians working on their own, or you had bigger clinics that maybe saw some eating disorders as part of general mental health or as part of a bigger clinic. You didn't really have the specialist eating disorder clinics with multidisciplinary teams, and that's something that I'm a real believer in, and that's what I wanted to be different. So it wasn't that you were applying kind of a general model to someone with an eating disorder, it's that you were combining kind of your therapy training with your specialist knowledge of what is helpful for people with an eating disorder. So to really create a specialist treatment approach.
What key therapeutic models guide your team?
I mean, I think that we are lucky enough to have a number of different models that guide the team. So that's one of the beauties of being in a team, right, is that you can offer different things. So as a multidisciplinary team, we're able to work really holistically across psychiatry, psychology, psychotherapy, family therapy, occupational therapy, dietetics. So whatever sort of discipline, if you like, is felt to be most helpful or most in line with what a client is telling us they think they need, we're able to offer that. But then even within those different disciplines, so if we look at psychology, you know, we're able to offer CBT, mantra, SSCM, schema therapy, speaks, EMDR. You know, there's a whole host of different therapeutic approaches that we're able to either draw on, or if we feel, you know, if we do an assessment with someone and we think actually what you really need is more of an attachment, more of a relational focused approach, we can refer within the team to that. If what we're thinking is actually we really want to do some sort of here and now symptom focused work, really help you with what's going on in the present, really understand that those links between thoughts and feelings and behaviours, and we can work on a more sort of structured here and now approach. That's the beauty of a team, I think, is that you're not tied to just one approach. You're able to really think about what am I hearing this person would find helpful? What am I understanding this person would find helpful, and then direct to that.
So within that, because of the broad team that you have, you're able to really hear and understand the client's experience, and based on that make an informed decision of actually this approach, this would work, this is, you know, this is an area that needs to be developed on, etc., etc. And sometimes, I dare say, there may be a situation where they go through all members of the team at some point for different areas.
Well, I really believe in MDT working. So absolutely, it might be the case that someone is, you know, meeting with our psychiatrist to think about whether medication might be a helpful part of their treatment plan, whether sort of assessment for different neurodivergent presentations might be useful in them thinking about what has led to them or contributed to them developing an eating disorder. They might be having regular therapy sessions once or twice a week. They might be having input from a dietitian, so that the dietitian can really hold the food stuff and let therapy therefore focus on what's underneath. Because often the problem with, or the difficulty with treatment for an eating disorder is there's so much there. There's so many areas that you need to work on. So having the ability to sort of split that out, and people have different roles within that, is really helpful. So, yes, I mean, it would be unusual that they'd see all members of the team, but being able to sort of see a mix of members of the team according to what we felt would be helpful is really a really wonderful thing to be able to do.
Nice. Many services treat eating disorders but don't focus deeply on body image. Why was it important to integrate both from the beginning?
I think because it's so central to an eating disorder, right? What that doesn't mean is that everybody develops an eating disorder because they have poor body image. So yes, absolutely. Some people start dieting because they want to be a different weight or a different shape, and they fall into sort of, quite an addictive pattern with that. But eating disorders, I feel, are very misunderstood in that for a lot of people, it's not really about changing it's not about their body image per se. So a real inability to tolerate being in your own body. The body is really a canvas, if you like, for reflecting how you feel about yourself or how you feel about the world. So no matter what has led to you developing an eating disorder, the body and how you take that out on the body is really central to that. And I think it's something that a lot of clinicians really struggle to work with or really, or don't prioritise enough. It's sort of tagged onto the end sometimes. But changing your relationship with your body and your ability to accept your body is really key to a lasting recovery. So I think it's so central to successful treatment to be able to do the body image work, not just look at the food or the emotion.
It's funny that you say that, because that reminded me, I was working with someone a while ago, and they came in to talk about one thing, and I sort of mentioned that actually there's some work to do in relation to your relationship with yourself. And this client was sort of a bit like, I don't know what you mean.
Yeah.
And as we did the work, she then came back and said, I see what you mean now. But again, I suppose it ties into the same, doesn't it? If the body image, the view of the body image isn't quite right, then the relationship with oneself isn't going to quite be there, is it?
Yeah, and vice versa, because often changing the body feels like something that people can change, right? There are so many cultural messages about the importance of weight or the importance of shape and the importance of looking a certain way. And I think especially, for a long time, growing up in the 80s and the 90s, all those cultural messages around the importance of slimness. But now with social media, it's just ubiquitous, right? It's absolutely everywhere. You can't really escape it. And so it creates this sort of environment, I think, where it's felt as though if I can change this, then everything will be better. If I can change this, then I'll feel differently. If I can change this, then my emotions will be better in some way. If I can change this, then I'll feel more in control. So because we are bombarded with this sense that we can and we should change our bodies, it can provide this almost false sort of solution, if you like, to our difficulties. But of course, the reality is that it doesn't actually change our underlying difficulties. And I think that's quite hard for people to understand.
And I suppose that might be more exasperated now when you've got almost quick fixes to changing your body shape in terms of gastric bands and slimming injections and all of that. I've seen or heard of it quite a bit where people sort of have that drastic change.
Yeah.
And then they have that realisation that, like I might like what I see better, but I'm still not feeling quite right.
Yeah. And I think, and all of those things that you mentioned have their place, sure. But I think we know that they need to be combined with good psychological treatment alongside. But that's not prioritised often. And the difficulty that I have with those quick fixes or, GLP-1 medications obviously are talked about a lot at the moment. Is I think it really does exacerbate this sense of the sort of over importance of looking a certain way and not thinking about the importance of feeling a certain way. It does provide a quick fix rather than, deeper level psychological work is hard to do, and it takes time.
And then the health implications. I think I read something the other day, and again, I don't know how reliable it was. It came up on social media about Robbie Williams saying that he is taking the injections and it's affecting his eyesight, but he's not going to stop. And it's like, hold on a minute, like, you're saying it's affecting your eyesight, your eyes. You've got one set of eyes, you can't change
But that just shows you the power of that message around the importance of looking a certain way. That people, and I'm sure he's not the only person to sort of, he absolutely won't be the only person to experience really challenging side effects and health side effects. But it's like the pursuit of thinness at all costs. And that's what I struggle with, is why is it that as a society we now feel it's that important? These medications were developed with people with life-restricting obesity. They weren't really developed for people like Robbie Williams.
And the research hasn't been done for people using it for that purpose. It's been done for, as you said, for people that are obese, that needed it to make, for the sake of their health, that weight needed to come off. It's not been done based on a vanity exercise to be slim, so you look nice in your dress, or,
And of course, it just perpetuates that message, doesn't it? The importance of thinness. But I guess what it doesn't do is it doesn't address, well, what is it that's affecting your confidence? Why is it that you feel that you need to look
a certain way,
different to how you do? What is that about? It's not doing that piece of work that I think can be a really valuable and important piece of work to do.
Just a quick break from today's episode. Let's talk about something that doesn't get enough attention: mental health at work. If you run a business, you've probably seen it. Stress, burnout, employees who aren't performing at their best because they're struggling. The problem? Most companies don't know how to address mental health in a way that actually helps their team. That's where Omnia Corporate Training comes in. We provide CPD certified mental health training that's practical, flexible, and designed to fit into any workplace. If you want to invest in your team's well-being, and let's be real, happy employees perform better, tap the link in the show notes or visit omniahealthgroup.com to learn more. Working with families, so eating disorders profoundly affect families. How does your approach involve and support parents, partners, and carers in the recovery process?
I mean, the answer to that, of course, is it very much depends on the individual system, on the individual family
system.
We know that for children and young people, the evidence-based approach is family work. So that's your first line treatment, if you like. Now, there's a lot of misinformation, I guess, in that what that means is that there's something wrong in that family system. Actually, what it means is that the family system is best placed to support that child or that young person to overcome their difficulties, that they're a resource. So it's not about blaming the family. It's not about placing causation within the family. It's about saying your family is your biggest resource. However, we also know, and there was a really lovely piece of research that was done recently that looked at the emotional toll of families of going through the experience of having a family member with an eating disorder. And there was a really high percentage of people that were reporting trauma symptoms, PTSD symptoms related to the experience of even, of supporting a child and going through a child having an eating disorder. It's incredibly demanding and draining and painful. And I think what treatment approaches potentially don't prioritise enough is the support for the family. Often the parents, the partners, the family members, they will think about themselves last. They'll think about, what do I need to do for my child or for my friend or for my partner? But it's much less common for them to sort of think about, what do I need to do for me to help me to also cope with the process of support. So that's something that we really try and do. And I think part of that is around offering them support. I also think part of that is around education, psychoeducation around what an eating disorder is, because they're so misunderstood and they're hard to understand, right? They're really hard to understand. So educating people to help them to understand what an eating disorder is and what the recovery journey looks like is a really important part, I think, of the work that we do.
And I suppose if they get that understanding of what that recovery journey looks like, they can almost brace themselves and get themselves ready for that, because it's
having
already
the expectations.
Yes, it's already been quite a grueling process already, and as you said, like the pain that it causes is draining, it's taxing, it does us
really
so
hard.
much.
It's really
funny
hard.
actually, because I had a conversation with the work that we do. We get asked, people come to us quite often and say, but I've got so-and-so and they're going through this, that or the other. And I stopped and I said, I'm really sorry to hear that, and that must be very difficult. And, I sort of made a few suggestions. I said, but I'm wondering, like, how are you?
Yeah.
And she was perplexed. She was like, oh, I don't matter. I was like, no, but you do.
But you do.
Because you're going through, yes, you're not actually going through it in the same way that person is, but you're supporting that person, which means that you are going through it in your own way.
Yeah, and that's a really lovely example of exactly what I mean, is that people are almost surprised by or struggle to acknowledge the impact that it's going to have on them. And it really is a significant impact. It can be hugely traumatizing to watch someone suffer from an eating disorder. So the support for them to enable them to be in the best place possible to support their loved one is vital, I think.
Absolutely.
Really vital.
Yeah. Because actually that person needs to rebuild themselves as well as the person actually going through the journey themselves. It is almost a matter of everyone rebuilding themselves together to get ready for the journey ahead.
Yeah, absolutely.
You mentioned this earlier, eating disorders are often misunderstood, minimised or reduced to appearance. What are the biggest misconceptions you encounter?
I mean, probably that one that it's all about appearance, which I think people associate with vanity. That, well, why don't you just stop? If you wanted to stop, you could stop, or seeing it as just about wanting to look better, I guess. But the reality is that eating disorders are severe mental health conditions, and that, yes, body image, as I said earlier, really comes into that. But an eating disorder generally is an attempt to block or control or to cope with an underlying emotional pain. It takes on a life of its own, of course. So it very much becomes about food and weight. And a lot of people will talk about a huge preoccupation with food, calories, weight gain. So you need to be able to have those conversations whilst also recognizing that, why is the eating disorder there? What function does it hold? And we talk about eating disorders as being egosyntonic. What that means is that when they start, they are functional in some way for that individual. They're not a choice. They're not someone saying, you know what would be really fun? I'm going to develop anorexia. I'm going to develop bulimia. They, and that function will look different for each person. So whether that's an attempt to cut off from difficult emotions, whether that's an attempt to feel better about themselves by achieving something that they feel will give them a sense of better self-esteem, whether that's a communication to others around something's not right. There's all sorts of ways in which an eating disorder can be functional. Of course, it becomes dysfunctional as it feeds into the very difficulties that it attempted to solve at its outset. But I think that's the biggest misunderstanding, is that people think it's just about wanting to look different.
Yeah.
Not really understanding the need, the desperate need to feel different.
And it just goes so much deeper than, as you said earlier, that surface level.
Yeah, so much deeper. And often people with eating disorders may come and they don't understand that for themselves.
Yeah.
They don't recognise the way in which the eating disorder has sort of bred from, a really early experience or a really early unmet need or a real buried difficulty that they have cut off from for so long that they're no longer aware of it. And being able to, or being prepared to see what might be there when you peel back those layers of the kind of over-evaluation of shape and weight is really key to treatment that is more likely to prevent relapse, I guess.
And in a way, it's so much more complicated because it's not like any other types of abstinence-based models, right?
Right.
That can create those new
because that's about
stopping
something, not about doing something often 6 times a day. Meals and snacks are not something that you can avoid.
No, you can't avoid. Your body needs it. You have to have that fuel. Whereas other abstinence-based programs, it's okay, you stop.
You think about how you remove yourself from those situations or you remove yourself from those triggers. But this is about going into the one thing that you find most painful. So if you think about sort of models for phobias, if you like, that, it's fairly well understood that if you want to overcome a phobia, you have to stop avoiding, you have to expose yourself to the thing that you're most frightened of. But when the thing that you're most frightened of is something that you have to face 6 times a day, or in the case of, often we'll think about eating disorders as a phobia of your body, a phobia of your body weight. Well, it's not just about exposure, you're living in that body. And that's really tough. And that's what makes treatment a difficult thing to do.
Wow. What does recovery actually look like? And I know that's a really broad question because, you've already said it's very individual, but on a general.
I mean, I would absolutely caveat that with recovery means what it means to you. And I think it looks different for each person. For me, there's something about freedom. There's something about freedom from the control that food has over you. Freedom from the emotions that people attach to their bodies. Whether or not, what that actually looks like in practice, I think really is different for each person. But I have seen enough people achieve that real authentic freedom to really believe that is achievable. Yeah.
Many clients experience anxiety, trauma, or perfectionism alongside their eating disorder. How do you support individuals with these layered presentations? Just a quick break from today's episode. Have you ever felt like the kind of support you need just doesn't exist? Maybe you need help outside of normal hours. Maybe you don't even know where to start. That's why Omnia Neurodiscovery exists. We offer specialised, flexible mental health support, including intensive evening and weekend packages for people who need something different. If that sounds like what you've been looking for, don't wait. Tap the link in the show notes or visit omniahealthgroup.com to find out how we can help.
By understanding the interplay between those things and eating disorder. So if we take perfectionism as an example, people will often then become perfectionist around their eating or perfectionist around their body. So they create these unrelenting standards for themselves that they have to live up to. So what you're then doing is, you're working on the eating disorder through the lens of working on their perfectionism. Same with trauma, I guess, is that when people are traumatized, what an eating disorder can often give you is a means to almost dissociate from that trauma, to block out that trauma or to feel more in control of that trauma. So it's really about understanding the link and then working with
Yeah.
them in unison, really. You can't address an eating disorder if perfectionism is a part of that without addressing the perfectionism. Equally, trauma. And of course, you have to think quite carefully about the trauma, because trauma work can be very, very difficult to do, and people need to feel very, very, very sort of well held in doing that trauma work. So what you don't want to do is strip back all of the means at which they have managed that trauma, i.e. the food rules or the food avoidance, if you're not then prepared to work on that trauma underneath, because you're just leaving people exposed to a core pain that they then have no means to deal with. So you really have to think together at the outset about what you're aiming to do within that treatment approach.
How do you feel that you adapt your approaches if someone perhaps may not fit in with the typical models that you're used to working with?
I mean, I think when you're in a few ways. I think if when you're working therapeutically, and a really important thing is to be regularly reviewing, regularly reviewing what you're doing, and if it's working towards those goals. I think the reality is that for a lot of people, they may need more support than your standard outpatient work. And I think historically what that has meant is that we would step up to perhaps daycare or perhaps even thinking about residential treatment sometimes. But there are all sorts of reasons why people might not feel that that's right for them, or may not be able to access those approaches. So one of the things that we are able to do within the clinic is step up intensity of support within an outpatient setting. You know, often people talk about therapy as being sort of talking the talk, but what is then really difficult is that to actually go and put those changes into practice in, you know, potentially sometimes that whole week before your next therapy session. So one of the things we've developed recently is what we refer to as our intensive outpatient pathway, which is the idea of combining different disciplines of psychiatry, psychology, dietetics, and experiential work to really give that boost of support when people just need a little bit more hand-holding and actually putting those changes into place. And that's something that as a team we're really proud of being able to offer is, you know, I think I spoke about it earlier when I said sometimes the problem with treatments that can be that when they're not working, the client gets blamed. There's a sense that it's, you know, there's something wrong with you that you're not benefiting from this treatment, or now isn't the right time.
You weren't ready.
You weren't ready. And I think actually that can be true, of course, sometimes, but I would really encourage people to look at, is there anything more we can be doing? And increasing the level of support or the intensity of support, or going out there and doing, you know, experiential work with people can be a really important part of just helping them move forward when they're feeling really stuck.
So sometimes having more of that handrail support system in place can really help the client on their journey of understanding the changes that are required in all areas of their life, not just simply coming to, a session once a week, perhaps.
Yeah. Exactly. Yeah, exactly. And of course, not everyone will need that, but there are times where people
that is needed.
might need that and will need that.
Dr. Bryony, thank you for sharing your expertise and the powerful work you do at the London Centre for Eating Disorders and Body Image. Your dedication to evidence-based care and compassionate support is creating real change in the lives of individuals and families. Before we close, is there a final thought you'd like to leave with our listeners as they navigate their own journeys or support a loved one?
So I think in terms of loved ones, don't forget yourself. I think that conversation that we had around the ease of deprioritizing yourself or not acknowledging the impact that it's going to have. So absolutely don't forget yourself, and remember that you are going to need support through this process too. And I think for people going through an eating disorder, find the right person, you know, that it isn't a one-size-fits-all approach. And finding a person that you really connect with, who can really think about what you need in order to be able to create that change and walk alongside you while you are going through those changes is key. So if you haven't found it yet, keep looking. You know, I'm not going to be the right person for everybody. My colleague isn't going to be the right person for everybody, but somebody out there will be the right person for you. And don't give up just because you haven't found that right person yet. Keep fighting to find that person.
To our audience, thank you for tuning in to the Silent Epidemic. If today's conversation resonated with you, please like, share and subscribe. Join us next time as we continue exploring the issues shaping mental health, recovery and well-being.